Hello, my name is Dr. Lin, and I completed my orthodontic residency at the University of California, San Francisco School of Dentistry postgraduate program in orthodontics. And I'm currently an assistant clinical professor at the University of California, Los Angeles. Today, I would like to share an interesting case treated under the supervision of Dr. Gary Reichhold when I was a resident at UCSF. Our patient, who was a 20-year, 9-month Asian male, presented with a cheek complaint. I have an overbite and my lip is too full. I would like to get Invisalign treatment to fix it if possible. His medical history was non-contributory and all his premolar were recently extracted. The patient presented with a convex profile, slightly retrognathic mandible, and retrusive chin. His nasolabial angle was slightly acute and the labial-mental angle was obtuse. His lip was slightly protrusive with lip incompetency, and he also shows a dolichocephalic facial pattern. Intraorally, he had a focused class 2 molar and canine relationship on the left and endon class 2 molar canine relationship on the right, with an excessive overjet for 8 mm. His overbite was within the normal limit, however the curve speed was deep. His maxillary midline was 1 mm to the right, and the mandibular midline was 1.5 mm to the left of the facial midline. Maxillary arch form was tapered, while mandibular arch form was ovoid with mild crowding on the maxillary arch and moderate crowding on the mandibular arch. Curve of Wilson was within normal limits, and his oral hygiene was poor with mild generalized gingivitis. We can appreciate more clearly on the model showing focused class 2 molar canine relationship on the left and endon class 2 on the right with excessive overjet, deep curve of speed, and normal to shallow overbite. The pretreatment panoramic radiograph shows centrally seated condyle bilaterally and a grossly symmetrical mandible. All the third molars were missing, and the mandibular right first premolar was tipped mesially. The pretreatment lateral cephalometric analysis shows a skeletal class 2 pattern with an orthognathic maxilla and a retrognathic mandible. Patient presented with a hyperdivergent skeletal pattern with an increased SNMP angle. His maxillary incisor were proclined, while mandibular incisor were in normal inclination, and both his upper and lower lips were protrusive relative to the E-line. The following treatment options were provided. Option number 1, comprehensive orthodontic treatment with extraction of upper and lower thighs along with orthognathic surgery, mandibular advancement with or without genioplasty. Option number 2, comprehensive orthodontic treatment with extraction of upper fourth and lower thigh, using full fixed appliances with NANS appliance for maximum anchorage on the maxilla and reciprocal anchorage on the mandible. Because of the dolichofacial pattern, we intended to level the curve speed with intrusion arch while limit the use of class 2 elastic for vertical control. Option number 3, comprehensive orthodontic treatment with non-extraction with a hybrid approach using bilateral class 2 carrier emulsion appliances to correct the sagittal first, followed by clear aligner therapy. Here is the final result. If you're interested in how this case was treated, please refer to the PCSO Bulletin 2025 summer issue. Thank you for your time and attention.